Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Today's podcast will focus on plaque psoriasis with Dr. Adam Freeman from the George Washington University School of Medicine. Dr. Freeman, if you could introduce yourself and give us a little information about yourself.
Sure. Hi, everybody. I'm Dr. Adam Freeman. I am professor and chair of dermatology, residency program director, and director of the supportive oncodermatology and the hidradenitis suppurativa clinics here at UW.
Okay, thank you very much. And we also have Dr. Joel Gelfand from the University of Pennsylvania. Dr. Gelfand, if you can introduce yourself and tell us a little information.
It's great to be here with you both. And I'm a professor of dermatology and epidemiology here at the University of Pennsylvania in Philadelphia, where it's always sunny. And it's great to be with you all today. People who follow my career, I do a lot of research in psoriasis, a lot of work in how psoriasis promotes cardiovascular disease, a lot of clinical trial work that my program runs, trying to understand what our therapies do to the skin, and as well as the cardiovascular system, and new ways to make clinical studies more relevant to patients and providers. And happy to be with you both today.
Okay, thank you very much. So we'll get started with the first topic is oral therapies for psoriasis, the evolving treatment landscape. So we'd like you to provide an overview of the role and place of the currently available oral therapies in the management of psoriasis, and we'll alternate, but Dr. Freeman, we'll start with you if that's okay.
Sure. So when we think about oral therapies for psoriasis, I guess we're kind of coming around full circle, because before we had this incredible armament of targeted therapies, I'm referring to the biologics. Oral therapies were our mainstay for more advanced disease, many of them being off-label, but these were medications that really more dropped weapons of mass destruction on the disease that really targeted entire cell lines. Medications like methotrexate, cyclosporin, which at the time would certainly enable us to do our jobs, but certainly with many limitations, especially when it came to safety. Then entered the era of biologics, monoclonal antibodies, but amidst the multi-decade journey of, kind of stepstone towards incredible treatments and of course therapeutic impact, we still were able to see oral therapies emerge amidst the clouds and the aura of the biologic revolution, and so we still have many options that also include oral therapies, and several new therapies that have emerged and more that are emerging, really at the end of the day, to provide patients with options. We want to personalize therapy, not just specifically when we think about the disease itself, but we want to give patients the ability to pick their path and use a therapy that is effective and safe, but also meets their needs, whether it be refusing any type of injectable therapy, which would limit our options, or someone who just feels more comfortable taking something daily versus every 8 to 12 weeks where, they forget to take their medicine until they recognize the prior authorization has run out. So I think the fact that we have both buckets and that both are still being fused with innovation and creativity, at the end of the day are just really important and helpful for our very large patient population with psoriasis.
Yeah, so we made a lot of progress in psoriasis, and yet we still need more treatment options for patients. This is a chronic, lifelong disease. None of our current therapies are curative. The biologics often have excellent treatment responses and are very well tolerated, but in a subset of patients that people lose response repeatedly to drug after drug. And some patients often just to avoid injectable medications for a variety of reasons. They want oral medication options. So it's just as Dr. Freeman mentioned, we have our old standbys. Acitretin can be very helpful for some patients, particularly sort of for pustular variants of psoriasis of the palms and soles, for example. Maybe in people who have underlying a lot of actinic damage, it can be helpful in that setting, so it sort of can reduce skin cancer risk a little bit, but not the most effective therapy, and really can't be used in people of childbearing potential, women of childbearing potential, I should say, because it sticks in the body fat for a long time and causes birth defects. So sort of a niche drug that's useful in certain circumstances. Cyclosporin, we seldom use these days because it's really limited use for 12 months. And there's a lifelong disease. What are we going to do for 12 months? And, decades ago, people would say, oh, it works so fast. And that was its niche. It doesn't work that fast, frankly. It really does. It doesn't nearly work nearly as fast as any of the biologics we use, the more modern ones. And a head-to-head clinical trial years ago compared to methotrexate, published in the New England Journal of Medicine, it worked just as fast and about as well as methotrexate did, which is to say, not that fast for the modern era. So it doesn't have a tremendous role to play given its issues with kidney function issues and complex monitoring, but occasionally it can be useful for patients. Methotrexate is still an old standby. For those who are still thinking about doing liver biopsies, that is a thing of the past. The newer guidelines really talk about doing non-invasive tests, things like a FibroSure test done fasting overnight. A blood test can be done, at any lab like LabCorp or Quest or a lab send-out. That's very sensitive if they're developing fibrosis. If there's concerns, they could have transient vibration elastography, a form of ultrasound that's used that also could pick up fibrosis. So this has made methotrexate easier to use, lower risk for our patients, and we never do a liver biopsy anymore. But it's not terribly effective. It can cause birth defects in women of childbearing potential, get pregnant, has drug interactions that can be serious, like using it in combination with, say, Bactrim, which is not uncommon. A patient gets a sinus infection, and lo and behold, someone gives them Bactrim. That could be a problem. And then, the branded products we have are things like Apremilast. It's been around for almost 10 years now, maybe more than 10 years. Wow. And patients like it because it's perceived to be very, very safe. No real risk of major side effects. It can make people have a little mood effect in some patients, make them a little depressed. It's pretty uncommon. It certainly commonly has GI side effects, nausea, queasiness. We did some interesting work on it that we published in JAMA Dermatology a couple of years ago, showing that it actually lowers visceral adiposity, which is the fat that surrounds the organs. That was pretty provocative findings. That suggests that Apremilast does something unique that may have cardiometabolic benefits based on those changes. But the downside of Apremilast is that it's not terribly effective. As you tell patients, if I give it to 10 people, maybe 3 or 4 are going to have a good response. The rest, not so much, And it's pretty rare to get someone completely clear on Apremilast. So for that reason, the enthusiasm isn't as strong for it in some circles, but patients really like it, and it's still one of the most commonly prescribed drugs. I often have to use it in combination with other medications, biologics, for example, people with very tough psoriatic disease, psoriatic arthritis. There's some new data emerging from Japan that it beats placebo for pollen plantar pustulosis, although again, the effects are pretty modest when it comes down to it. And then finally, we have deucravacitinib. This is a TYK2 inhibitor. It's in head-to-head studies clearly more effective than Apremilast is. Clearly better tolerated, meaning that people are much less likely to stop it because of these GI side effects. But because it's a TYK2 inhibitor, that's in the JAK pathway, and there's some lingering concerns about the long-term safety of it. And it's a new drug, so we need some more data to fully understand it. I think that medication, if we didn't have all the biologics, would be an unbelievable advance for us. But with all the biologics we have available, those therapies, generally speaking, especially ones that target 17 or 23, are generally going to be probably more effective than deucravacitinib. And therefore, usually when we're balancing the risk, benefits, and alternatives, I personally tend to steer people towards biologics, but I've had plenty of patients who want to be on a pill, and when they've done it, they respond pretty well, even patients with really tough to treat diseases.
I think Dr. Gelfand brought up some really important points about the place for orals, how they're perceived, why maybe one that has superior efficacy is still trailing way behind in terms of utilization and prescription numbers. I think the first point that really resonated was, do we need more medications for psoriasis? I mean, we have such an incredible armament for a disease that affects 3% of the population. And the answer is still yes, because of the fact that so many different cases are unique in terms of how they respond to therapy, or if they do respond, is that response maintained. Many psoriasis patients are certainly no stranger to therapy switching, or as was mentioned, combination therapy, obviously off-label. But the reality is we need these options because there are going to be a good number of patients that we do have to double down and give an oral as well as an injectable, or we're going to have to switch gears every couple years because there's a loss of impact. So I don't think innovation is wasted here. I think certainly it's needed. But I think, the point that really stuck out to me about the fact that, yes, you have deucravacitinib, if there were no biologics, it would be the probably most effective medication we have for moderate to severe psoriasis. Yet, forgetting the biologics, putting it against apremilast, which they did in the phase 3 studies, it is still trailing behind. So that really speaks to what is the driver for decision making. And I think efficacy isn't at the top of that list, at least based on this, that really safety and tolerability, and tolerability probably doesn't fit either, right? Because it is more tolerable. That safety really is the number one driver for decision making. And, it's a challenge for us, not just for us in our own practices, but also in educating our peers who won't reach for the more effective therapy.
Right, yeah. And we should probably say what we mean by safe. I think as dermatologists, we tend to be very conservative and very demanding for a very high safety profile. A drug like deucravacitinib is a very safe medication. It's very rare to have to stop it for a side effect. An individual prescriber using that drug is unlikely to have a problem. But there were a couple of lymphomas in the developmental program. It has a warning for that. There are probably a higher rate of certain type of infections, viral infections, things of that nature. For those who aren't as familiar with the mechanism of action, it's probably modulating some of the cytokines that we think about for psoriasis, IL-12 and IL-23. And IL-12 is a little bit more of a more broadly immunosuppressive cytokine compared to IL-23. Maybe that's why it was a little signal in development and has a warning from the FDA, which you don't see with the 17s and the 23. There's no warning for lymphoma, for example, with those drugs. So as a practical matter, I think it just takes time making sure the patient understands the benefit for the medications, the low risk of things, and help people feel reassured when it's the appropriate treatment for them. Because oftentimes we overweight a small risk of something that we're worried about, right? Something that we're unlikely to see in our careers.
I think one way to easily combat that is put the ISI of Tylenol next to anything, and it really gives you some perspective there.
So I guess just to finish up in this topic, are promising agents on the horizon, if you could comment on that. It looks like maybe there's an oral IL-23.
Yeah, these are very exciting. So J&J has an oral peptide. And so the major advance people need to know about is that before we felt large molecules, protein structures, or small proteins, peptides, basically, that you have to inject them. You're not going to get them through the GI tract. Well, through a series of advances in biomedical engineering, they're now able to get peptides through the GI tract. It's able to tolerate the high acid content of the stomach and get enough absorbed. And so what that agent does for J&J is it's a very avid blocker of the IL-23 receptor. And in clinical trials, it has very impressive efficacy. Now, it's not a head-to-head trial of that drug versus deucravacitinib that I'm aware of at this point in time. So I can't say it's definitely more effective than, say, deucravacitinib, but it probably is. And the safety profile looks very good in your earlier phases. Assuming it behaves like an IL-23, it would likely get the same label that we would see with any IL-23, which is a pretty simple label. And so that potentially could be a real blockbuster, especially if the agency finally decides we don't need to screen for tuberculosis. Because with the IL-23 inhibitors, they've been around for a long time now. There's really no clinical evidence that they reactivate TB that I'm aware of. There's actually a few case reports of 17s doing it, even though it's really rare, and plenty of clinical trial data for both 17s and 23s showing that people who have, PPD positive, that they don't reactivate on these drugs. Now, usually they're getting treated for having latent TB, but it would be unreasonable if the agency said, it's safe for people who have a history of have unknown TB status, just go ahead and go on it. That would make it more like apremilast, but very high efficacy, right? it has to be taken on an empty stomach. It'll probably be a once-a-day drug, but that's not so easy. Taking something on an empty stomach is often challenging for people. And so real-world adherence and efficacy will remain to be seen.
Okay. Well, thank you very much. Dr. Friedman, do you have anything to add to that?
No, as well said. I think I'm equally excited about this new direction of, hopefully biologic equivalent orals, and it's a mix of, advance in the actual active itself, but also in drug delivery, because that's one of the biggest issues in terms of stabilizing these molecules to get them where they need to go. So I think that even though we have so many options, both probably more biologics, injectables versus oral, there are more orals coming, which just gives us more options, and more options are less problems, in my opinion.
Right. Mm-hmm. Okay. I appreciate you guys' time today, and we have a lot of good information, and that was a really good discussion, a good summary on that topic.